Hello everyone and welcome back. So we are going to discuss the hematology in this section and we will start from our first topic, that is iron deficiency anemia. So we are having a scenario that there is a 2 months old breastfed infant and HB is 7 gram. He has no family history of anemia or blood transfusions. He has no skin rash or hepatosplenomegaly. So what is the history questions, the causes, the FBC and RBC indices, the advice to the mother and the treatment with dose and duration of the therapy. Another scenario is that there is 2 years old child brought to you with the history of increasing pallor for past few months, no history of fever or blood loss. Parents complain that he looks weak and short as compared to his age group children. He is youngest of his 3 siblings. So what are the history questions, the important clinical findings, the differential diagnosis and the investigations? Now the definition of iron deficiency anemia. It is a disorder which is characterized by iron deficiency, results in microcytic hypochromic anemia, and the causes are dietary lack, impaired absorption, and blood loss. Dietary lack is inadequate intake, impaired absorption is in celiac diseases, and the blood loss or hookworm is in hookworm infestations or GI blood loss, peptic ulcer disease, or inflammatory bowel disease. Now, the clinical features of iron deficiency anemia are mild, moderate, severe, and other symptoms. In mild iron deficiency anemia, the patient is paler. In moderate, there will be weakness and fatigue, decreased exercise intolerance, tachycardia, tachypnea, and systolic heart murmurs are present in moderate case. In severe case, congestive heart failure, cardiac dilation, shortness of breath, and hepatosplenomegaly. These are the severe clinical features, and the other symptoms are koilonychia, angular chelosis, pica, and atrophic glossitis. These are the clinical features in the case of mild, moderate, severe iron deficiency anemia. Now the investigation options are, first of all, HB is checked, which is low in iron deficiency anemia. Reticulocyte count is checked, which is normal or elevated. RBC morphology is checked, which is small erythrocyte with decreased HB will be present. MCH and MCHC is checked, which is reduced. Serum iron is decreased. Iron binding capacity is increased, and capacity is increased. Serum ferritin level is decreased, and bone marrow examination shows microneuroblastic hyperplasia. The differential diagnoses are microcytic hypochromic anemia, anemia of chronic inflammation, and beta thalassemia, that is lead poisoning. The treatment options are iron therapy is given. In mild to moderate anemia, this treatment plan, and in severe anemia, we are having this plan. So for mild to moderate anemia, oral elemental iron, that is 4 to 6 milligram per kg per day is given. Iron is given with vitamin C to enhance its intestinal absorption, and parenteral iron if oral is not tolerated. Then the underlying disorder is corrected, and dietary counseling is done, and the cause is corrected. For severe anemia, RBC transfusions may be required for severe anemia that results in congestive heart failure. Okay, so this was all about the iron deficiency anemia. We have discussed a scenario that there is HB of 7 gram, which is decreased, and there is no skin rash or hepatosplenomegaly. In another scenario, there is history of increasing pallorness, and the patient look weak and short as compared to his age. So what is anemia? We have discussed the definition that it is a disorder which is characterized by iron deficiency, and it results in microcytic hypochromic anemia. The causes are dietary lack, impaired absorption, and blood loss. The clinical features are mild, moderate, severe, and other symptoms are koilonychia, angular chelosis, pica, and atrophic glossitis. Okay. Okay. So this was all about the iron deficiency anemia. Now let's discuss the idiopathic thrombocytopenic purpura. 2 weeks ago, there is no hepatosplenomegaly or lymphadenopathy, and labs show normal HB and white cell count, and platelet count is 15,000. So, the definition of idiopathic thrombocytopenic purpura is that it is autoimmune condition mediated by autoantibodies and directed against platelet membrane glycoprotein 2B or 3A. Acute ITP is due to infection, and chronic ITP is the history of 1 year. And there is persistent ITP and refractive ITP. These are the types of ITP. Now, the differential diagnoses are leukemia and aplastic anemia and disseminated intravascular coagulation, lymphomas, and SLE, systemic lupus erythematosus. The investigation options for ITP are that clinical diagnosis is done, bruises, fatigue, and rashes are present, CBC is done, and there is isolated decreased platelets, and PT and APTT is normal, WBC is normal, and bleeding time is prolonged. Peripheral blood film, there is decreased platelet and gained platelet, and viral serologies are done, that is HIV, HCV, HBV, and EBV. Now, the treatment is supportive treatment and pharmacological treatment. In supportive treatment, restricted physical activity and avoid trauma. Avoid medication that suppress platelet production, for example, aspirin, heparin, chloramphenicol, sulfonamides, carbamazepine, valproic acid, and digoxin, etc. Pharmacologically, intravenous immunoglobulin, that is 1 gram per kg per day for 1 to 3 days is given. Steroids are given, which is 2 to 4 milligram per kg, that is prednisolone. And anti-RSD factors, that is 50 to 70 microgram per kg per day for 2 days is given. And splenectomy is done for chronic ITP. So this was all about the ITP. That is, we have discussed the scenario in which the main clinical features are blue spots of different sizes over the body, and epistaxis on and off, and mild pallor, and there is no lymphadenopathy, hepatosplenomegaly, or joint pain. In another scenario, we are having the blue spots of different sizes, and also petechiae is present, and there is the history of epistaxis and bruising. So this was all about the ITP. We have discussed the scenario, then the investigation, and then the treatment options, the different types of ITP, and in the treatment options we are having supportive treatment and pharmacological treatment. So we have discussed this. Now coming towards the next topic, that is thalassemia major.